the presentation, we will definitely get to them. So please type them in as they come up into the box on the lower right-hand corner, and we'll make sure we get to them. Again, we'd like to thank Golden Dental Solutions, the organizer, for hosting this educational event. And most importantly, at the end of the presentation, stay tuned for any specials. So this evening, we'll be talking about creating autogenous graft from extracted teeth. Again, I'm Dr. Ara Nazarian, a practicing dentist in Troy, Michigan, also the director of the Ascend Dental Academy and mentor at Amplify Dental. These are the types of patients that are presenting to the dental office. And it doesn't matter where your practice is, whether it's in the US or internationally, these are the types of patients that are presenting. It could be one tooth that was endodontically treated that may have broken off. It may be multiple teeth that have periodontal disease, or it may be teeth that are just non-restorable because of severe bruxism or caries, or also periodontal disease. But these are the types of patients that are presenting to my practice. We thought with the advent of fluoride that we would not have this much dentistry to perform treatment on. However, we're finding that in fact more and more people are presenting to our practice with conditions that are very severe, in fact. Well, one of the reasons is because of an aging population, the baby boomers. And according to the literature, age is directly related to every indicator of tooth loss. So as the population matures, so does the possibility of losing a tooth, whether it's a single tooth, multiple teeth, or the whole dentition. In addition to the baby boomers, we have the young generation, where we see a lot of the processed drinks and processed foods causing severe decay. We also see an increase in methamphetamine use. Well, one thing to keep in mind is with young patients like this that have hopeless dentitions, to just give them dentures is something that may not be a solution, because by the time they reach their 50s, the bone would have resorbed to such a level where their removable prosthetics would no longer be good or comfortable for them. So we want to think about implant therapy for some of these patients as well as the baby boomers. Let me show you an example. This patient presented, and you would never think that this patient would invest in getting 16 implants and getting full fixed over fixed bridge work on implants. So you never want to prejudge your patients. You want to offer the best treatment that's possible for all your patients, because some will, some won't, but if you don't offer it, none will. And here we can see the occlusal aspect of how we were able to restore this patient's dentition to normal health and function as well as aesthetics by extracting these teeth atraumatically, utilizing the physics forceps, grafting the areas, and then in a second surgery coming back with guided surgery and placing 8 over 8 implants. Well, what does this mean to us as dental providers? It means that there is a huge potential for your practice to grow. So if we have this huge potential, why have more general dentists not performed extractions and grafting? Well, they were scared of not being able to get the tooth out. They were also scared of damaging a blood vessel, a nerve, or breaking off a root tip that they would not be able to get or retrieve later on. They were also scared to having to reflect a flap or having to have a huge armamentarium of products to be able to extract the tooth. And most importantly, some of these procedures were not getting reimbursed properly for the doctor or the provider, and so a lot of dentists try to just avoid it and refer it out. In addition to these, we also have assistants that would have to originally set up a huge selection of instruments. Well, we'll talk about the physics forceps in just a moment and how easy it is to extract a tooth and it doesn't require a lot of force or a lot of time to be able to perform these atraumatic extractions. So what is our goal today? Today, you will learn how to tap a growing market of patients needing multiple extractions. We'll show you proven techniques to atraumatically extract teeth in a predictable and efficient manner. We'll also go over an overview of the different types of grafting materials that are available and the pros and cons of each, because there's a variety of different types of grafting materials that we have today in our armamentarium. What do you feel is going to be the best after this presentation? And then we also have the importance of grafting following an extraction. We know from clinical experience that it's much easier to preserve than to try and create later. So to place grafting material into a socket is much easier than trying to fill the void later with advanced grafting techniques. And then lastly, we do want to focus on how easy it is to create autogenous graft material in minutes from the patient's extracted teeth. So let's take a look. First, we want to focus on the definition of an ideal tooth extraction. And this is defined as the painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals without compromise and no post-operative prosthetic problem is created. So not only do we want to get the tooth out, we want to get the tooth out with minimal trauma to the surrounding tissues and create a situation or a foundation where later we can place an implant. So let's take a look at a single extraction example. This patient presented to the practice. She had had endodontic treatment on this tooth, and a temporary was placed in the access opening, and the patient, of course, was instructed to return to her general dentist and have a core and crown restoration. Well, the patient was no longer in pain, so she didn't return to her general dentist's office after the root canal was performed by the specialist, and once the cavity and the cotton pellet dissolved from the access opening, recurrent decay developed and the tooth was no longer restorable. So utilizing the physics forceps, our goal was to atraumatically extract this tooth. And some of you may have seen the presentation before. There's quite a few videos on the YouTube. If you just Google the physics forceps or Golden Dental Solutions, or even go to Golden Dental Solutions website. But essentially, the physics forceps works like a modified class 1 lever, as you see in the schematic. And it allows you to remove the tooth atraumatically. So how do we place this forceps onto a tooth? Well, the first step is to take the beak of the forceps and place it onto solid tooth structure. So if you find that there's decay and you can't get onto solid tooth structure, you may want to take a 169 burr and make a purchase point on the solid tooth so that you can engage the beak on the solid tooth structure. The second step is to take the bumper and place it as high up into the vestibule as possible without squeezing. Remember, we're going to use this as a class 1 lever. So without squeezing, we're going to rotate or lever this tooth out of the socket into the path of least resistance. So using this buccal rotation, the tooth is successfully rotated or leveraged out of the socket. Once the tooth is loosened, then we can use forceps. We can use the tooth delivery system available through Golden Dental Solutions to further remove this tooth from the socket. So if we take a look, we've applied the physics forceps, and in some patients you're able to go higher up with the bumper. In this patient's case, we weren't able to place the bumper that high up because her vestibule was not deep, but you can see the leveraging action of the physics forceps. And here, the results. We were actually able to get a whole molar with 3 roots that were all divergent out in one piece without breaking the buccal aspect of the ridge or breaking any portion of the root. Now remember, In the posterior maxilla, usually we have type 4 or type 3 bone, so there is some expansion, but we are not breaking the buccal plate, as you can see in this photo. Now, we've also noticed that the patient has decay on the mesial aspect of tooth number 2, and she was instructed that when she comes back, we need to address this. Our goal and her chief complaint was to get the tooth out that was causing discomfort for her because of the recurrent decay and abscess into the area, or infection, I should say. So we clean the socket out very well with a curette. And traditionally, we've placed particulate graft or some type of membrane into the area, as you can see in this photo, allowed it to heal. And this is 4 months later. You can see we have a nice ridge, a nice foundation where we can very easily place an implant without having to reflect a flap, and just use a tissue punch to go ahead and place approximately about a 5x10 implant. Notice we've already done a cleaning for this patient and restored the tooth and gotten her back to good oral hygiene and good oral health. And so now she's ready for an implant. Well, what about multiple teeth? Well, we've done very similar types of things. Utilizing the physics forceps, we'll take these teeth out and graft, as you'll see in just a moment. For patients that are not sedated, especially for these single teeth or a couple teeth here or there, I like to use the VibraJet, and what this does is it vibrates the syringe so that it's sending a bunch of impulses to the brain, and the brain can't differentiate the impulses that are coming from the VibraJet or the impulses that are coming from the sensory neurons from the pain of the pinch of the needle. Another nice thing that you can use in your practice is the Anutra anesthetic system that we also do teach at our residency in our programs. So once the patient is anesthetized, we'll go ahead and separate the PDL. This is the Golden Dental Solutions extraction and grafting kit. And using the Orban knife, what we'll do is sever the PDL and separate that from the tooth, as you can see in these photos. We'll go all the way around the tooth, starting from the facial, going in approximately, and then finally to the lingual or palatal aspect. Then what I like to do is implement the separators. The separators essentially are inserted vertically into the PDL space in order to not only further sever the ligament, but laterally expand the socket to create a larger path for the delivery of the root structure of the tooth, especially when utilizing the physics forceps. This is not needed with the physics forceps. However, because I place a lot of implants, as well as our other mentor, Dr. Tim Kaczynski at Golden Dental Solutions, we like to implement this as much as possible because we know later we will be placing implants in these areas. So here you can see where I'm using the separators, and I'm further going deeper into the PDL space, enlarging the area, and further separating the PDL fibers. And we'll go all the way around using the various 3 instruments in the separator kit. And finally, we'll go ahead and utilize our physics forceps to atraumatically extract these 2 teeth. So we've gotten tooth number 8 out atraumatically. We continue on to tooth number 9, and here we see there's no buccal plate of bone remaining on any of the teeth. It is intact fully in the sockets. So what we'll do is we'll actually reflect a flap so that our viewers can see that even though there is a thin buccal plate, utilizing the separators as well as the physics forceps, we were able to get this out atraumatically. Before we do that, we'll definitely make sure that all the granulation tissue is removed from the socket. That is one of the essential procedures that we implement before placing any type of grafting material into the socket. So we'll go ahead and curette. We'll initiate further bleeding and make sure that any granulation tissue is removed. At this point, we're going to reflect a flap so that our viewers can see that the buccal plate is fully intact. So we're using these instruments from the Golden Dental Solutions grafting kit. And here we can see, utilizing the separators and the physics forceps, we were in fact able to remove the teeth atraumatically without breaking the buccal plate. In this case, we used the epi guide. We placed that into the buccal aspect, and then we used a regular Goldos DBM putty, also available from Golden Dental Solutions. We pack that in, fold it over. We make sure that we're at least 2 millimeters apical to where the level of the bone was. So we're 2 millimeters apical to where there may be any type of void or the ridge. And we're going to go ahead and suture these with PTFE sutures, the monofilament, and the patient goes out with her flipper. We allow this to heal, and 2 weeks later, when the patient returns, already we see that this area is healing very nicely, and in 4 months this area will be ready for implants in the number 8 and 9 area. So let's quickly look at the reasons for socket grafting, and then we'll review the different types of grafting material, and then we'll focus on how we use extracted teeth to come up with an autogenous graft. So what are the main reasons for socket grafting? Again, as we talked about earlier this evening, it's much easier to preserve than to try and create later. So we definitely want to place grafting material, whatever your selection may be, at the time of extraction. That's the ideal time to do it. If we look at number 5, again, it's much easier to preserve than to try and create later. Also, patients really don't want to go through 2 surgeries if they don't have to. Later, when that area of number 8 and 9 heal, we can easily go in with just a tissue punch and not have to reflect a flap, because we know we've already set the foundation, and keep the procedure very simple and effective and efficient. And we never know what the financial situation is going to be of the patient later on. So these are a variety of different reasons that were published in Clinician's Report in May of 2010 of why, what, and how we should be placing socket grafting material. Well, what are some of the different types of grafting material that are available today? Well, we have xenograft, and you can see some of the most common xenografts that are available. A xenograft being from an animal other than human, and usually we're going with bovine or horse bone. Usually it's bovine is what we've seen used in the past for xenografts. We also have allografts, and allografts is bone derived from humans, and they're derived from the cadavers, and they're treated and prepared in such a way that there's no disease carried over. And usually, for the most part, most people have been using allografts, and there's a variety of different ways that it's applied, whether it's in a particulate form, a gel form, or a putty form, and there's a variety of different distributors of that. Third, we have alloplasts, and alloplasts are more synthetic types of bone that are available, and usually we see this as a calcium phosphate, hydroxyapatite crystals. Osteogen is a very common one that we've seen, and that's something that Golden Dental Solutions provides. It has the osteogen that's carried in a bovine Achilles tendon type of foundation of a plug that works very well. But really, if we look at the most ideal bone, what is the most ideal bone? Well, autogenous bone, obviously, from the host. It's osteogenic, it contains the osteoblasts, and it has the potential to really grow bone the best and a faster regeneration. But what have been the disadvantages of autogenous bone? We know that it's better and it's accepted by the host much better because it's from them. But what have been some of the disadvantage of it? Well, no one really wants to have a second surgical site where they have to trephine some more bone, whether it's in the mental region of the mandible or the ascending ramus. We just don't want to have to create another surgical site that a patient may complain of discomfort or possibility of morbidity of that site or a suture line opening in that site. There's definitely added time for the dental provider or the surgeon, because now they do have to reflect another area and expose that area so that they can either trephine or use a piezoelectric handpiece to section out a block of bone. And then lastly, we've seen that sometimes we'll find that there is a high resorption rate. The turnover is faster. So sometimes if it's an area where there's a larger void, we found that there is a higher resorption rate. So how do we create an autogenous bone grafting material without some of these disadvantages of having to create another surgical site, of having to add more time for the dental operator or the surgeon, or an area that may have a high resorption rate? Well, the solution this evening that we want to talk about is the Smart Dentin Grinder. You can easily create autogenous graft from extracted teeth. So we're going to focus on that this evening. So what is involved exactly? Well, first, we're going to extract teeth atraumatically with the physics forceps, and the extracted teeth from the patient is going to be the source of the autogenous graft material. Now, it's imperative that we don't use endodontically treated teeth because we don't want to have to sit there and try to remove the gutta percha and try to dish out some of the remnants of those materials. We also want to make sure that we remove any type of restoration, any type of remnant tissue that may be on the tooth, and we'll focus on this in just a little bit. Second step, what we want to do is grind this down, right? We want to grind this down into small particulate type of graft, and then what we're going to do is we're going to go ahead and treat this with some different chemical agents that we'll be talking about so that we can cleanse this graft material and remove all the bacteria from there and have a graft that's created chairside in a matter of 10 to 15 minutes, where it actually has the natural growth factors already in there. It's got a better scaffold, and we'll talk about that in a moment, with an accelerated healing time. So let's take a look. Well, we've been fortunate enough to have Professor Itzhak Binderman. He's in the Department of Oral Biology and Department of Biomedical Engineering, and he's done a variety of different studies for several years looking into the similarity between dentin and bone. And a lot of this material will be available on the Golden Dental Solutions website, but he is the gentleman who has come up with this idea of the dentin grinder and using these teeth instead of discarding these teeth for a graft, an autogenous graft material that is useful, faster, more economical, and it grows and turns over to bone very nicely. So what are the 4 steps again? Number 1, we're going to clean the tooth of any caries, of any tissue, of any restorations, whether they're amalgam or composite. We want to just have tooth structure, which is including also the root. We're going to grind and sort these teeth, these extracted teeth. Then we're going to cleanse the granules, and then we're going to rinse them off and dry them. So let's look closely at how this works. Well, the Smart Dentin Grinder is actually a very powerful little unit. We can change the grinding time, but usually only 3 or 4 seconds is necessary to grind, and then we'll sort those materials within about 15 to 20 seconds. The beauty is it can grind particles to 250 to 1200 microns, so we have a variety of different sizes depending on how much you're going to grind that. We can sort the larger particles in the top shelf and the smaller particles, almost like a sand of the particles in the lower, to be a little bit of a filler. The machine is very powerful. The blades are very powerful as well, and we'll talk about the process in just a moment. Usually when we're placing the teeth in here, we're going about 5 teeth at a time. We don't want to put more than that because we don't want to clog the steel blade, but usually 5 teeth at a time is what we'll go. So step 1, Here in the slide, you can actually see how I've cleaned the teeth out that we'll be using in the Dentin Grinder. So we want to clean the teeth of any debris, any caries, or any restorations. We do not have to remove nerve from the tooth. However, we do not want to use endodontically treated teeth. Okay? Secondly, we're going to go ahead and set our grinder for about 3 to 4 seconds, place the cover on, and grind the teeth for 3 seconds, and then 20. If you find that there's still remnants of tooth particles within the top portion of the grinder, then you can go ahead and grind for another 3 to 4 seconds and sort for another 10 to 20 seconds as well. The beauty is one tooth provides approximately 3 times its size in grafting. Okay. So here we can see, just by doing the first grinding cycle and a quick sorting cycle, how much graft we have on the top shelf. We also have the sand that's on the smaller particles on the lower shelf. So we're going to remove the drawer with the 300 to 1200 micron particles and place that into the sterile cleansing dish for defatting, dissolving any organic debris. So all the tissue that you were concerned about is going to, as well as any toxins in the dentin graft. I'm going to place it into the sterile cleansing dish to remove all the debris, toxins. How do we do this? Well, it comes with a kit of the cleanser and also the saline water. So first step, after we've ground the teeth down and placed it into our sterile dish, we're going to take the basic alcohol cleanser cap vial and compromised sodium hydroxide, 30% alcohol. What we're going to do is wet all the particles so that they are all within the solution. And the particulate dentin should be immersed for 10 minutes. We don't want to go any less than 10. Studies have showed that 10 minutes is the exact amount of time that is necessary to remove any of the toxins and bacteria from the dentin particulate. In fact, there's quite a few articles on there they've scanned with a scan, and you can see in the third photo to the right that the test was actually growth. So 10 minutes that we want to soak in the alcohol solution, hydroxide and alcohol solution. Poured any excess of that solution out. Go ahead and fill this up with the phosphate buffered stick. Allow the material to be wet, remove the excess saline, and then do it again. So we're going to do it twice. Then we're going to go ahead and decant the excess saline using sterile blot in order to remove excess moisture. Sometimes people will put it on a dry heater or something warm to further dry the material. What I found is going through these steps is more than enough to get a particulate that's ready to place into the socket. This is what particulate looks like. Place direct to the grafting site, the extraction site. You can go ahead and load this like you would any grafting material and syringe it into the of. So here we have a bacteria-free autogenous dentin graft. What have we found with this? Well, even with the histology reports, we can actually see that the dentin truly form bone matrix. The beauty is autogenous bone that may resorb faster, the enamel down in this tooth and provided in this graft, this particulate graft, actually work as a scaffold. So what you find is that even though this is an autogenous graft material because it's taken host, it's there to the apatite particles of the enamel allow that scaffold to stay in place enough so that the other smaller dentin particles start turning into bone or resorbing and turning over into bone, and the enamel will later also convert, but it's a nice scaffold and it doesn't resorb very quickly. It holds its position quite well. What we've also seen is it's not just one or two scientific papers that we've seen printed about this. Again, Professor Binderman has done a lot of research. He's put a lot of time and effort into this to focus on this biomaterials and really look into bone regeneration and really compare dentin and bone and how similar they really do act. And so I definitely recommend you take a look at these papers. So real quickly before we show you a few cases, what are the Smart Dentin Grinder? We get faster bone healing, will be restoration at a much faster rate in comparison to autogenous grafts or to non-grafted sites, obviously. The beauty is it is there too. There is no rejection, there's much less inflammation, and fast resorption, there's no inflammation, there's no rejection, which is nice. Immediate stabilization, very little, if any, recession. Again, because we have the granule particles of the enamel as sort of a scaffold, while the dentin particles are turning over and the host bone is being replaced into that area. And we also have bone remodeling. We don't have to worry about if it's like a synthetic bone that we're going to have to drill into something that feels equivalent to glass bone, something that's going to be very spongy and not very good, or doesn't have the cells, the bone morphogenetic cells that are going to help this really turn into nice, healthy bone placement. Myself personally is an response. I found that they have very little inflammation. Tissue responds very well to this. If primary closure, we're obviously still going to use a membrane, and you could use your membrane of choice, whatever you're comfortable with, whether it's a pericardium or a synthetic EpiGuide. They all work very well. But if you don't have primary closure, we definitely want to have a membrane, or if you have more than a one-wall defect, you still want to use a membrane dentin graft. Most importantly, when we look at some of the larger cases where I'm entire dentition in somebody's situation, as you're going to see in a moment, it totally reduces the graft cost. So for a full arch, traditionally what I've paid is almost $800 to $1,000 in graft material because we're going through several cc's of purchased graft. When we're using the Dentin grinder, when we grind the teeth down, not only do we have more than enough graft material to fill the sockets, but it's no longer costing us that much to do, and it works much better. So let's take a look. Extractions, leveling, grafting, and immediate implant placement. What we're going to show you again is the dentin graft material. So here we have a patient that presented to my practice for a consultation, and he had some mobility on the lower teeth, and the upper teeth had some recurrent decay, and he knew that he was ready for dentures. So we talked to him about possibly going with some fixed options, and he said that was just any, it was not in his budget to be able to go with full fixed. So he said, if we're going to convert you into denture, then the minimum that we want to do, at least on the bottom, is to get you 2 implants with some type of attachment. In this case, we use the locator attachment, or you can use an O-ball attachment to provide an overdenture in the lower arch. So the first thing we did is we went ahead and scanned him to confirm that he would have adequate width for implant placement. This is the Carestream 8100 3D, and this machine is a very nice machine. I have it in my practice. It allows you to get 2D and 3D images from just one machine. Just looking at the 2D image, we can see the recurrent decay in these teeth, but also we can see the periapical lesions that we definitely want to clean out very well before we place any type of grafting material. So this gentleman's treatment plan was to essentially extract all the teeth, level the bone, remove any granulation tissue or infection, grind the teeth down, and use them for a graft, as well as place 2 implants in the canine to premolar region. Well, although we were still going to freehand this, the beauty with the Carestream software is that I could 3-dimensionally plan where our goal was to place these implants, as you can see at the cross-sectional views, and be able to maintain some of the ridge and graft some of the other parts of the ridge. The first thing we do before we do any surgery is get a preliminary impression so that our lab can fabricate the immediate dentures. And in this case, we use the Silginat from Kettenbach. This is an alginate alternative that can be poured up multiple times. You can see how nice of an impression we were able to achieve with this material, and we were able to engage enough of the vestibule so that our lab can very easily fabricate immediate dentures. So now that our immediate dentures are available a few weeks later, we have sedated the patient and we anesthetized the patient. Utilizing the separators, we're going to go ahead and sever the periodontal ligament around these teeth. And we're going to go all the way around, starting from the interproximal, in this case, to the facial, and then wrapping all the way around to the palatal. Then we place the beak of the physics forceps on the palatal aspect, the bumper as high up as possible into the vestibule, and we start extracting the teeth atraumatically. And so this is what it looks like. Then we're going to go ahead and curette this area out, remove any type of granulation tissue, and in this case, we didn't have to graft the upper ridge. If we wanted to, we can grind those teeth and use those in the area. My concern was more for the lower arch where we're replacing the implants. So here we're going to try in the immediate denture. And because there was only really 2 teeth, we didn't really have to soft reline this immediately. In the lower arch, we're going to go ahead and utilize the separators to sever the PDL and expand the sockets so that we can get these teeth out atraumatically without breaking bone and without ripping any gingival tissue. So here we see this. And then utilizing the physics forceps again, we're going to atraumatically remove these teeth. So here we've extracted all and remove from some of those sockets. We're going to go ahead full flap. Here we have a solution kit, and it has essentials so that you're assist around for all the separate instruments. And the mucoperiosteal elevator kit, we're going to go ahead and reflect a flap. We expose the area where there's several layers of granulation tissue, so remove that. And then we're going to go ahead and level the ridge, not entirely, but enough that we don't have these sharp undercuts. And utilizing our images from the scan, we're going to go ahead and create pilot holes for our 2 implants. In this case, my selection was utilizing the Engage implant from Moco Biomedical. One of the reasons why I prefer this implant is because the immediate stabilization of this implant, especially the primary stability. But the patented bullnose auger really pulls the bone in and allows you to load or progressively load, as you can see from the lower right schematic. Tapping body works very well in these types of cases, but all cases where you may be placing a fixed temporary. However, this patient's budget, he could only afford to go with immediate upper and lower denture, and the lower denture was going to be an overdenture, obviously, to engage. Notice the sharp tip that allows and pull bone in that area. You'll notice that it's a machine and it still maintains its cutting. So now we're ready to go to the dentin graft. The first step, clean the teeth of any debris of artery or calculus, any caries, or of any restorations. So we'll go handpiece and remove any of this debris. Again, the nerve is not necessary to be removed. However, if the tooth was an endodontically treated tooth, we do not want to use that in our dentin particulate graft. So this is what the setup looks like. And later, Kurt from Golden Dental Solutions can talk about that there after the event this evening. So we go ahead and we place some of the teeth into the, we grind and we start to particulate graft. This is what it looks like before it's. Now we're going to take 3 more teeth and place those into the graft, overload the grinder. So usually I go 3 to 4 teeth at a time. So here, what type of, whether it's granularies or restoration, and you can see we've cleaned that quite well. We'll put those into the grinder as well. Grind for 3 seconds and then sort for about 20 seconds. Additional graft cleanser, we'll put these in the cleanser for about 10 minutes. And then once the 10 minutes are over, our phosphate healing to go ahead and remove any of that chemical agent off of the graft. So we'll usually wash it twice and blot any excess moisture. And here you can see we've placed our Engage implants. I've immediately placed the locator attachments. That's how confident I am about the implant having immediate fixation and stability. And then in the areas that we saw the voids, where we clean the granulation tissue or any remaining sockets, we're placing our dentin graft material. Here we're using the PTFE sutures, and what to do is place the things onto this area and just do a soft line at the moment until our soft heals nice. So in this case, we're using the muco. This is a very nice soft realigned material. Checking the bite, firming everything, having him bite into place. This is not soft reline. The lower soft reline areas to attachments, a very firm attachment, but there will be some retention until this area. Notice nicely the ridges heal. But more importantly, look at the bottom. In the lower arch, we see that there's still just a that needs to heal, but the dentin graft has the issue surrounding this. This is only weeks later, and because I'm comfortable with the Engage immediate fixation, especially with the auger tip, I went ahead direct pickup at the 2-week mark. Here we see the radiograph. Notice you can actually see the radiopacity of the graft material, and that is the dentin graft. That's the enamel particle also with show very radio opaque on an X-ray, which is also a nice highlight. So looks like before and after. Another case. This patient presented, again, non-restorable dentition. In this case, we went ahead and scanned the dentition and soft tissue. This is 600. This is a very nice intraoral scanner. I've had a chance to review one that I've purchased for my practice. We can go ahead and convert these over for the laboratory area with the scan. Here we can just have with this logarithm those areas in, and also the lab fabricated immediately ready. For surgery, we're going to go as the patient. We're going to go ahead and use our separators, sever the PDL, and then utilizing our physics forceps, extract all the teeth. Here we have the grafting kit that's laid out. Again, this is from Golden Dental Solutions. We curette all of the sockets, and then any root tips we'll be using the root picks to remove. We'll cleanse these areas and then curette to confirm that all the granulation tissue is removed. And then the teeth that have no restorations, or even the ones that do have restorations, if there's a crown on it without a root canal, we can section that crown off or just section the tooth and maintain the root structure for the Dentin Grinder. Here we see illustrated how I'm curetting the area out. We want to initiate bleeding, but most importantly, remove any type of infection or granulation tissue from the area. Here I'm reflecting the flap further, and using the bone file within the grafting kit, we're filing this down. Here you can see the teeth that were cleaned and any caries and tartar and restorations removed. And look how much graft material we already have. This is before it's treated. Here we're going to allow the material to be treated and cleansed for 10 minutes and then rinse it with saline twice, and now we have a graft ready for the sockets. So now we're placing the graft material in the sockets after we've done some leveling, because this patient did indicate that they were interested in possibly getting implants in the upper arch as well. We went ahead and sutured this and put the immediate denture, tried that in. And then utilizing the separators, we went ahead and severed the PDL and used our physics forceps to atraumatically extract the teeth, as well as the root picks to take any remnant roots out. At this point, we're going to go ahead and reflect a flap. And since we did a scan and we merged it with the digital impression, we're able to identify the areas that we would be placing the Engage implants. So we wanted to place 4 in this patient's case because she paid a little bit more and we wanted a little bit more stability. And she showed interest of having 4 implants placed on the top for an overdenture later. Once the implants were placed, we confirmed that the dentures fit and articulated well, so we soft relined the upper and lower denture. As you can, in the lower, we're relieving the areas of where the healing caps or the locators will be. And then we soft reline both, allow this to heal. In this particular case, we did allow it to heal for because the couple of the areas were not as stable as we would prefer, so we didn't want to risk it. We used the new locator system, the RTX, and again, with this, you don't need a special tool, you just need a 050 hex driver, which is in everybody's implant kit usually. And again, we can control the pounds of retention that we'll be using. So once the area healed, we place the locators into the area with their recepting housing caps. Here we have a reinforced denture with a metal framework where we do a direct pickup. And in this case, we use the Tokuyama hard reline. You can see we've removed the black processing ring from the locator RTX. And so and here you can the deep 4 implants to create a kind of supportive low. One through very here, a lot of at the Institute or at the University of Detroit Mercy for the Amplified Dental and some. How are you getting all these cases? You through a whole scenario real quickly, whole process. What we do is find out what of the patient, and from that point, photographs, digital photos of going on. Present this to the patient, we have these views on the screen. And many times I've heard from the patient, I can't believe my teeth, because they've never seen their mouths like this with a retracted shot or an occlusal view. And so this really helps when you're doing the case presentation, whether it's dentures, overdentures, or in this case, this patient accepted fixed over fixed. So the initial appointment, we collect the data like everybody else, but in addition to that, what we'll do is capture images with our intraoral, with our camera intraorally and extraorally. We'll get models, whether they're digital or actual models, whatever you're comfortable with, and then we have the CareStream 8100 3D, so we'll also get a scan. We'll identify all the areas that need attention, and if these teeth need to come out. In this case, you can clearly see that this patient does in fact need to have full mouth edentulation. And so we'll show you that here in the scan. So here we have a 3-dimensional rendering of what we've achieved from the scan. And if you take a look in the number 11 area, you can see there's a huge void. In fact, the gum tissue is the only thing that's holding this tooth in. So the treatment options we offer to our patient for the maxilla and the mandible are removable denture, some type of an overdenture, or some type of fixed restoration, whether it's on 4, 6, or 8 implants. So we go ahead and present this to the patient. She's interested in getting fixed over fixed and not wanting to do any sinus lifts. So this, in fact, was the treatment plan of choice. Here's a close-up rendering. This was done by 3DX. And so again, we're going to go ahead and take impressions with the Silginat from Kettenbach. Again, this can be poured up multiple times. We don't have to worry about it shrinking or drying up until your assistants have a chance to pour it up. We can actually send it like this to the laboratory. And here we've identified to the laboratory what we want. And so what we have is not only this bone level surgical guide, we have an immediate denture and also immediate fixed restoration in case we do get enough torque and a good reading on the Ostel unit to be able to provide fixed. And we have that also for the top as well as the bottom. And on the bottom, we're also going to be doing quite a bit of leveling, as you can see here. This is a bone leveling guide, the surgical guide, the immediate denture, and the immediate fix temporary. So the day of the operation, we anesthetize the patient, we atraumatically extract all the teeth, we go ahead and grind the upper teeth once we've cleaned them of all caries and tissue and restorations. While that's happening from one of my assistants, I'm going to go ahead and reflect a flap and curette the sockets of any granulation tissue. Remember this there's a ton of granulation tissue area. And so now we're going to go ahead and level the bone. Using our guide, we're going to place this on, and it's our implants. This kit from Oko Biomedical. It's a very easy system to use, type of guided surgery. In this case, it will be X. Here we have the implant tip. So place is poor quality of bone, initial stability is canine area, low ISQ reading, place of. We're going to go ahead and soft realign that denture. In the lower arch, we're going to atraumatically extract the teeth, grind those teeth and remove first caries very well, and then grinder, sort them, and then go through the steps earlier in the evening. We're only going a few teeth at a time, not to clog the grinder. At this point, we'll be placing the bone leveling guide on. That is sharp. Place our universal surgical guide. Our implants, and in the see the threads. We don't want to bone all the way area. We want to go ahead and use our graft fill sockets that you may see. These area where you still see some thread. See where we've used the grinded particulate areas. We've covered it and then placed the stock abutments in there, as you can see, and we realign our fixed immediate temporary. This is what she looks like 3 weeks post-operatively. When she comes back 3 months, we remove the temporary, and using the AMD laser Picasso soft tissue laser, we remove any of the excess tissue so that we can easily prep these stock abutments and take a full arch impression using the Panasil impression material and have the lab fabricate a full bridge. Deliver the much faster. We're allowing the upper area of the had replaced at the bone table. So 4 to 5 months, we went ahead, removed the healing caps from the engaged implants and tested, and we clearly had a very high number. So at that point, we knew we could take it and come with restorations on top and bottom now. Here's the occlusal view of the maxilla and the patient's final cosmetic and functional. I like to identify dental training at the University of Detroit Mercy. We actually are able to utilize these instruments as well as the Dentin Grinder on live patients. So I highly recommend you listen to the specials that are offered through Kurt after this presentation. Also, I am the clinical director of Ascend Dental Academy, so I invite you, if you want to learn about the Engage implants that have the immediate fixation and dual stabilization technology, to log on to Ascend Dental Academy. I'd like to thank you for paying attention. We have a residency coming up in Chicago, April 28th and 29th, advanced grafting, very much like the procedures using, as well as guided surgery. And Academy. Again, Ara Nazarian, Troy, Michigan, and I liked. And Kurt, why don't we open some questions and then we can hear some specials? Does that sound good, or would you like to review your? I think Kurt is logging. So one find the Detroit Mercy, we work on lines, is the fact that we are able to extract teeth. In fact, at the last course, um, what happened was we were actually able to take about 300 teeth out. So it is a very busy 2 days when we do this process of extracting teeth and placing this grafting material. There's a variety of different grafting materials that you'll be able to try, so it's not just the Dentin graft, but you'll also get a chance to use particulate allograft, synthetic graft, osteogen, and this way you can clearly make a decision on what you feel comfortable with in doing these types of procedures in your practice. Because let's face it, the number of these patients are growing exponentially, whether it's the baby boomers or the patients that are drinking these sugary foods or drinks or power drinks, or even sometimes even the drug use, as you saw. There's a huge potential for your practice. Kurt, are you ready? I see his screen is coming up. Okay, I think he's just got a little technical difficulty. So let me answer some of the questions. I'm reading one of the questions and they said, what is usually the turnaround time that you're finding for the Dentin graft material when you're placing implants? In the upper arch, what I found, it's usually about 2 to 3 months, and in the lower arch, it's usually 3 to 4 months. So what we're finding is that this area, because it's an autograft, is changing over faster, and the quality of bone is much better, probably about 3 to 4 weeks faster than what you would expect with a particulate graft that may be an allograft, and obviously much faster than a synthetic graft. Another question that we also hear is what does it feel like when you prepare the area for an osteotomy? What does it feel like when you're going with that first pilot drill? Does it just drop right into the area, or do you feel some resistance? I can tell you when you're drilling into a Dentin graft, 9 out of 10 times, I feel that bone to be like a D2 type of bone. And that's what we want. We want a D2 type of bone, which is the most favorable for implants, because we still want blood supply to get to the area. We don't want it to feel like we're drilling through a Coke bottle, and we also don't want it to feel like we're drilling through styrofoam. So I urge you to try the Dentin graft material, or to come to the residency and try it on our patients that come to this school for free dentistry, to allow you to get the ideal training that we offer to our patients. So one of the things that we'll see is that Kurt, once he's on, he'll talk about the courtesy, professional courtesy, which is 10% discount on anything that you've seen this evening. If you call on the line or you log on to the website, please make sure that you use Web10, and that would be Web10, WEB10, to take advantage of the 10% courtesy on any product that you see in the special. Also, if you log on to Ascend Dental Academy, you'll also follow that this will also go into the area. So let's real quickly take a look at the slides and see what we have. I'm just trying to log on here. Yep. Yep. I hope everybody can hear me. For some reason,
reason I appear to be permanently muted on the line, so I apologize for that. So I'll just start to go through the questions here, if just to respect everybody's time. I guess, Ara, the first question that came in was if you could explain a little bit further, what the quality of bone is like when you go back to drill for implants when you're using the Spartan Dentin Grinder from the Dentin Graft. I guess, what are you finding the quality to be using this system?
Right, so the quality of bone that I found when we're drilling back into the Dentin graft is a nice D2 type of bone. As mentioned, it's not too hard like a D1 where there's no blood supply or it feels like you're drilling through a Coke bottle, but also it doesn't feel like styrofoam that we may have experienced with other grafting materials that are out there. So it's a very nice bone with a great consistency and, most importantly, a great blood supply, because the blood supply is important and essential for an implant to be successful.
Okay, perfect. If you wouldn't mind, I guess, can you go over again, in general, what the cost per use is for the Spartan Dentin Grinder, and really what the practicality is of its use? Are you finding you're using it more for single cases, or is it more practical in your practice, I guess, to use when you have multiple teeth?
Great. What I'm finding is very similar to the examples that I illustrated this evening. I'm using it for multiple areas. However, one could use it for single unit teeth replacement. I found that when you're doing multiple units, all of a sudden when you're using grafting material from a bottle and you're buying that, it gets quite costly. So I find that I'm usually doing it for multiple teeth, whether it's 2 or 3 teeth or more, as compared to the single tooth, just because of the time. Because otherwise, with one tooth, I find, I'm ready to finish up before the 10-minute period. However, there are a lot of clinicians out there that do use it for a single tooth. So whatever you're comfortable for, what to use it for, is good with me.
Okay, perfect. There was another question that came in about, do you have any concerns about, for example, and maybe you covered this already, and I apologize when I was trying to be unmuted, but as far as the timing for the clotting, some people had asked, was there any questions or concerns with having to prep the extracted tooth for the dentin graft that could take 13 to 15 minutes or so in the process while the patient's waiting? But maybe you already covered this, where I think you clarified that for the most part the staff can be preparing the tooth and using the Smart Dentin Grinder while you're leveling the bone or doing other procedures. I guess, is that not really a concern in your experience with the product?
It's not a concern, because I do have a staff member that is going ahead and cleaning the teeth of any restorations and caries and things like that, and prepping. So if you notice in the grinder, I only had a few teeth at a time. So what I try to do is, as the teeth are being extracted, if I get 3, then I'll make sure my other assistant goes ahead and starts grinding the teeth, so it's not a problem. If you're doing it yourself and you do get clotting, what's the solution? So if you start to get clotting, then you would go back in with a curette and initiate some bleeding. Now, we have smokers, and smokers, smoking is a vasoconstrictor, so sometimes these patients don't get really nice bleeding in those areas. What I do recommend is going in with a surgical burr and maybe decorticating the bone to initiate some bleeding if you don't have any bleeding at all. So I think that is also imperative. So if you're doing it yourself and you don't have another assistant that can do this as you're extracting the teeth, and you do end up getting some clotting, then I would dislodge that clot with a curette and initiate some bleeding again, or decorticate the bone if they have no bleeding at all.
Okay, great. There's another question that's just more, I guess, implant related or in preparation for implant with a graft. I guess in your experience, if you do graft a socket site, and you're not going to place the implant or restore the, or place an implant for potentially maybe 3 to 5 years, I guess each patient might be different. But in your experience, I guess, how long can you really wait in your experience before you might be able to place an implant after doing a graft?
Great question. So usually what I tell my patients is you have up to about a year before this ridge starts to resorb. Bone needs to be stimulated, and it's usually stimulated in one of two ways, either by the tooth with biting force or by the implant. So if the ridge is not stimulated, then you will get some resorption of that ridge and atrophy of the ridge. So 3 years later, I would guarantee you that that ridge may not be the most ideal after any grafting procedure to wait that long. So I would say I would give my patients up to a year, but I can honestly tell you that 9 out of 10 times when the patient has a tooth that's been missing already for 3 to 4 months, they're ready to get it restored as soon as possible.
Okay, perfect. I could probably take, there's a couple questions I'll combine here, but some people ask, what are the physics forceps and what are the different sets? Just to clarify that, I know the focus was on the Dentin Grinder this evening, but of course you have to extract the tooth to be able to graft the socket and then ideally place implants if it makes sense in that case. But anyway, so the two different sets are the standard series set, just to clarify, is 4 instruments. There's 3 uppers and 4. So that there's an upper right, upper left, upper anterior, and a lower universal instrument. That set will generally cover second molar to second molar on the upper and lower. That's the set that if anybody on the webinar this evening is not using our product or was curious how it works or if they wanted to try to implement it into their practice, the standard series set would definitely be the instruments that you would want to evaluate and see if they'd be a right fit for you to make extractions more predictable and less traumatic in your practice. That set's going to give you the best leverage, and again, it does cover the full mouth for the most part. You're not going to get to wisdom teeth just due to the access restriction in the patient's mouth being able to reach to those posterior regions of the mouth. But that's a good set to see if the product's the right fit, because like I said, you have, I think we said before, we have 90 days to evaluate the product to see if you like it and you like the concept. The other set of 2 is the molar series. They're angled differently to reach further back into the mouth. You do lose a little bit of your leverage with those instruments, but it does serve the purpose of extracting erupted thirds, your hard to reach second molars, and it could work on first molars too. However, if you have both that, the standard series set's going to probably be the instrument of choice, assuming you can get access due to the leverage that it does provide. The other instruments, just quickly, the separators that Dr. Nazarian helped us develop and get manufactured. There's a set of 3. There's a straight, a curved, and a bayonet. And you can take a look at those on our website at physicsforceps.com. Those are a great adjunct or pre-stop for anybody that's already using our product now. It's a great instrument to prevent any tearing of the tissue, to start to sever the PDL, and to just start the atraumatic extraction process. We've had great clinical feedback from people that are using the product, and that's something that I think would be worth taking a look at for anybody that may already be using our product. I guess one other comment I just wanted to make, I guess, I know Ara mentioned our Amplify live patient programs that we do here in Detroit. We have a couple questions on that. Some people asked, I'm in Canada, can I attend? And then also some people asked, if the program's in Michigan, would it matter if I'm licensed out of state? And the answer to those questions are, we do it at the University of Detroit, which is the teaching facility. And so doctors from Canada or the U.S. are more than welcome to attend the program, and absolutely any dentist that's licensed outside of the state of Michigan, located in the U.S. or Canada, can work on the live patients that we provide. So it is a very comprehensive live patient program. We see generally anywhere from 65 up to 85, even 100 at times patients, depending on the number of attendees. So it absolutely is a hands-on training program. And Dr. Ara Nazarian is, of course, one of our instructors at that program. You can learn more about those programs. If you do go to physicsforceps.com, you can find a link to get to our educational program. So you'll find more information under Amplified Dental. So it's just AMPLIFY dent.com. So anyways, I think that probably covers most of the questions we had this evening. I wanted to thank everybody for investing their time with us this evening. And we will be sending through email the CE letter for joining this evening. So please be patient with us. We get a lot of people that join these webinars, and we will make sure that we get those out likely by early next week if you don't receive it this week. So again, I want to thank Dr. Nazarian for speaking this evening, and everybody else investing their time with us. As you can see, it's been up on the screen the whole time I've been speaking. For anybody that wants to take advantage of any of our products, or to see how the grinder works, or if you're interested in that product, it's a great opportunity to save 10% by using the promotional code of WEB10. You can give us a call here in the office anytime tomorrow or this week. Our number here is 586-585-1210. And again, the special is valid for, we do it for 24 hours. It's a quick special. We know your time's valuable. We want to provide a savings for investing your time with us this evening. So again, the promotional code will be WEB10, and we're more than happy to answer any questions you may have this week on any of our products here at our office. So again, I just want to thank everybody. Have a great evening, and please look for future webinars from us in the future. Good night, everybody.
Great. Thank you and good night.